I'd like to welcome everybody to this fourth in our COVID-19 virtual seminar series. And the title of today's program is Ensuring Wellness in a Changing World. Just a few housekeeping items to start out with. The first one is no microphone or video capabilities are needed to participate. And also at any point during the webinar, you're able to ask questions. Now you can do this anonymously if you wish, or add your name. The benefit of adding your name is that if we don't get to a live answer during the program, we will get back to you after the program with an answer. Also, this webinar is recorded, and a shareable link will be provided to all of you after the event. So it's my pleasure to welcome what really is an all-star lineup this afternoon. The first one, our presenter is Ann Prestipino, who is Senior Vice President of Strategy and Clinical Operations for both the Mass General Hospital and the Mass General Physicians Organization. But these last couple of months, basically Ann's day job has been put aside. And Ann has been overseeing our hospital incident command system, which was actually stood up once we first became concerned about the possibility of a COVID pandemic near the end of January. And I honestly do not think Ann has taken a day off since the end of January. Ann has been preparing for this for almost 20 years. When the idea of a hospital incident command system was first brought forth at the federal level after 9/11, Ann was the one who took responsibility for this and has served as incident commander for a number of situations, including the Boston Marathon bombing and the Station nightclub fire. So let me just start off by expressing my deep appreciation to Ann for all that she has done. We're also joined by Pradeep Natarajan. Pradeep is a director of our Preventive Cardiology Center here at Mass General. We'll also be hearing from Jonathan Rosand. Jonathan is a critical care and vascular neurologist. He's co-director of the Henry and Allison McCants Center for Brain Health, as well as the managing co-director for the Mass General Center for Neuroscience. And finally, Dr. Maurizio Fava. Maurizio is our Psychiatrist-in-Chief in the Department of Psychiatry here at MGH and is director of our Clinical Research Center at the Mass General Research Institute. And Ann, I will now hand things over to you. Ann, I think you're on mute.
Sorry about that. Can you hear me now?
Yes.
Thank you very much for your kind remarks and introduction. And I'd just like to extend my welcome and thanks to all of you that are joining us this afternoon. We are delighted to be with you and to have an opportunity to talk a little bit about what life has been like here at the Mass General over the last couple of months, and to hear from many of our clinical experts about the importance of wellness as we go through the recovery phase now of this very challenging pandemic. So just by setting things in context a little bit, I thought it might be important to start with a few numbers. So in the United States, these are numbers as of this morning during our incident command call, and I'm going to explain a little bit more about incident command in a moment. But in the United States, there are about 1.7 million identified cases of COVID-19, and the corresponding number for the state of Massachusetts is about 94,000. I'm delighted to say at Mass General that we only had 127 inpatients this morning that are COVID positive. 51 of those patients are being cared for in our intensive care units, and another 76 in our general care units. Now, in addition to that, we have about 100 other patients that are in a category we refer to as COVID risk. And that means these patients have come in with some type of symptoms related to the virus and are in the process of being evaluated and tested to see exactly where they stand relative to this disease. It's also important to note with respect to these numbers, even though they are large, at our highest, and others may have reported this to some of you in previous forums, we were close to 450 patients in-house during the surge, the highest point of what we saw as a response to the pandemic here in Boston. Another important fact, though, to point out is that during that time period, and quite frankly, this has been over the last 11 or 12 weeks or so, only about 20% of our inpatients are COVID or COVID-related patients. The remaining 80% of our inpatients have been non-COVID patients. So in other words, they're here being cared for other types of diseases, injuries, issues. And we're very proud of the fact that we have been able to maintain our capabilities to care for people who unfortunately are not suffering from the virus. And we're very excited and positive about our recovery plans, which I'm also going to speak to. I think it's important that I also explain to you a little bit more about what this incident command system is all about that Dr. Nicholson noted at the beginning. So for many years, we have had what's referred to as an emergency preparedness plan, and that is our overall plan for the organization in terms of how we will respond to any type of hazard, any type of emergency that comes our way. And we actually utilize that plan for things perhaps as fundamental in the New England area as a snowstorm, but also for these unfortunate large-scale disaster situations. For us, our greatest experience, as Britt has pointed out with a couple of examples, have been more in the mass casualty arena. And what's very different, obviously, about this situation as a pandemic is it's a very longitudinal kind of situation that has really disrupted our operations, if you will, for obviously a number of weeks, if not months. The incident command system is a structure, consider it a tool, excuse me, that's used interior to the emergency preparedness plan. And that tool basically allows us to go into more of a command and control structure, which is very necessary for rapid decision-making with very clear lines of authority and roles and responsibilities for different positions, if you will, in what becomes our new organizational structure for these types of scenarios. And I've had the privilege of serving as the incident commander during this pandemic situation. And I have to say that my colleagues have just been phenomenal partners in this, as we have really responded, I think, in a very organized way to what we have encountered. There are several sections in the incident command system, such as operations, logistics, planning, and finance, as well as the whole command staff that really help to keep us organized around the various issues we need to contend with during this kind of a scenario. So during the course of our response phase, obviously, we had to do some very dramatic things here at Mass General. And again, it was through the remarkable talents of many, many people, including obviously our clinical staff, our physicians, our nurses, our respiratory therapists, but also supportive staff, folks like our biomedical engineers, our environmental services folks, that literally turn general care units into ICUs to help support the care of COVID patients in a 1 or 2 day time period. It was pretty remarkable to see how quickly this was done, and with great expertise and competence. There were some very creative things that were done during this time period. We are blessed with a great depth of talent in critical care expertise here, both on the physician and nursing side. And we spread that talent as broadly as we could and paired people from other disciplines so that they became quasi-critical care providers, if you will, always under the direction of experts in the field, no matter where they were actually caring for patients. You heard a lot about, I'm sure in the public news, about personal protective equipment, or what we refer to as PPE, and how we needed to be very careful about the utilization of that equipment so that we were using it in the right way for different kinds of patients that were presenting at different levels of care, or levels of need, I should say, with respect to their clinical condition. We were guided by all of this through CDC guidelines, as well as our own infection control experts, who really helped us critically think about what needed to be worn in particular circumstances, be it face shields, be it masks, be it gloves, be it gowns, etc. And we've done, I think, a pretty remarkable job in thinking creatively about how to manage this important resource, which needless to say has been a challenge across the country. On the technology side, things such as ventilators have also raised concerns in many other parts of the country. I'm delighted to say that we were very, very fortunate. We had done a complete inventory before this all started, and we're able to really optimize the utilization of our ventilators, including the use of some of our anesthesia machines, which could be used for ventilator purposes as well. We have had some of the sickest patients in the city cared for here. We also worked extensively, however, I should say, across our system to make sure we did everything we could to share the burden, share the responsibility, and we tried to level load patients across the system so that they could be provided with the best possible care by virtue of not overwhelming any single one of our hospitals. That being said, Mass General definitely was probably the recipient of the highest number of COVID patients in the Partners Healthcare system. But now I just want to spend my last couple of minutes talking about recovery. In this phase of work, we're working very diligently to make sure we continue to do the appropriate screening and testing of all patients coming to our institution. Any patient that's going to be admitted is tested to see if they are COVID, to make sure, again, we are utilizing the right protective equipment and doing the right things in the care of that patient. Any of our patients coming to the ambulatory world, we are making sure also are screened. If they have any symptoms, they go to one of our specified areas for special testing to make sure we understand their COVID status. And again, that we can appropriately protect them and protect the caregivers as they go through the process of care. We are doing everything we can to make sure that we keep our employees healthy and well. We are making sure that everybody coming into the organization has to complete what we refer to as an attestation, which means they have to really carefully think about whether or not they have any symptoms. They have to go through a little questionnaire on an application process, either on paper or through an app on their phone. And assuming that they are symptom-free, they come into the organization, hands are sanitized, new masks are given. We ask that all of our patients and all of our staff wear our issued masks because we know that they're safe and will protect you. And we currently have a very, very limited visitor policy. And that won't change until the governor changes the state policy with regard to numbers of additional people we're bringing into the organization. Of course, there are situations where we make exception to that, such as the case of a new baby being born, or people who are unfortunately are dealing with end-of-life kinds of issues, to make sure that family members do have an opportunity to be with their loved ones. Our cleaning intensity and frequency has definitely increased, and we are making sure that we are cleaning all high-touch surface areas. We have added hand sanitizers throughout the campus to make sure that we are making those cleaning opportunities available, again, both to patients and to staff. And finally, we are trying to rearrange some of our physical space. The aspect of social distancing, or as Dr. Slavin likes to say, physical distancing, is very important, even while wearing a mask. And we have encouraged this, obviously, with our workforce, and we continue to do that with our patients and the small numbers of visitors that we have entering the organization. So we feel very ready and able to continue our work, not only in taking care of patients who come to us with the virus, but also patients who are coming to us with any other issue or challenge. And we are, as I say, very, very happy that we had the privilege of taking care of many of these patients, and we had the expertise and the necessary tools to do so. So with that, I would like to turn the program over to my colleague, Pradeep, who is going to now speak to you from the vantage point of cardiology. So Pradeep.
Thanks, Anne. And thanks again for the opportunity, Britt, to share my perspective and the strategies that we're focusing on in cardiology, including how we've dealt with the initial surge and transitioning towards wellness and recovery. And first, I'd like to say that the coordination from hospital leadership with Anne at the helm and her team has been phenomenal, swift, thoughtful, evidence-based. So as a clinician on the front lines and a wife who is also a clinician on the front lines at MGH, thank you very much, Anne. So early in the pandemic, with initial reports from Italy and in China, it was clear that patients with cardiovascular disease and risk factors such as hypertension, type 2 diabetes appear to be at the highest risk for developing severe COVID and associated complications. And sometimes there were reports of individuals developing severe cardiovascular complications related to COVID. And there were also early reports that folks who were developing cardiovascular emergencies, like high-risk heart attacks that may have had nothing to do with COVID, were just not coming to the hospital because they were scared. And what was concerning to us was those reports were being replicated in the US, particularly early on in the pandemic. There was a recent report of which we contributed some data from MGH and healthcare systems across the country. Roughly about 40% of heart attack volume went down as far as people presenting to the hospital. And this is the flavor of a heart attack that's an emergency that you need prompt medical condition. Now, we're worried that in the coming weeks, we'll see some of the complications and sequelae of that. And it's important for us to maintain connections with our patients to minimize this from happening. So, in parallel, as the incident command team has been meeting, our cardiology team has also been meeting essentially nearly on a daily basis virtually. We have representation from various aspects of cardiology on the invasive and interventional electrophysiological side, the inpatient group and the outpatient group, the various different forms of testing like nuclear testing and echocardiography. And we focused on several aspects, and I think the relative emphasis has evolved dynamically as the pandemic has evolved, and also with guidance from hospital leadership. So first, and most importantly, we adapted our workforce and care models to rapidly provide high quality inpatient cardiovascular care to those with COVID, and generally also provide to the hospital's capacity and bandwidth to provide high quality COVID-19 specific care. Second, and simultaneously, and as Anne indicated, increasingly so, we've maintained our work streams and bandwidth to ensure that cardiovascular emergencies, regardless of COVID-19 status, are promptly dealt with. As Anne indicated, the majority of the hospital volume is now increasingly shifting towards non-COVID-19 related care. But since we all still have COVID-19 on the mind and are spending a lot of time and effort in preventing the spread, including in the hospital, the coordination of cardiovascular emergencies, COVID or not, requires thoughtful coordination for testing procedures, and all that needs to happen rapidly and quickly. And we've developed those systems to be able to do that. Third, and this is important for this, for this next phase, is altering our outpatient care delivery models. We obviously had to do that rapidly initially in the pandemic to make sure that existing patients as well as new patients can be seen by cardiologists to advance their cardiovascular care. What we've been most concerned about are the folks who really urgently need medical care and are afraid, appropriately so, to come into the hospital, and doing the best that we can remotely, but also providing systems and measures for them to get high quality care and in person as necessary. And fourth, and a last point I'll touch upon a little bit at the end, is that many of our cardiologists are also highly accomplished physician scientists, and that's obviously not just cardiology. That's throughout our health system, and including throughout MGH. And at least within cardiology, we formed a specific cardiology research task force to really address high priority scientific issues related to the COVID-19 pandemic as it relates to our patients within our healthcare system, but most importantly, to support the global response. And I'll touch upon some concrete examples. So at least concretely on the inpatient side, we converted an entire cardiac floor dedicated to COVID-19 cardiovascular care. That was a unique innovation that hadn't yet been applied to any other health system, given the volume that we saw at MGH and the complexity and the specialty care that we're able to provide. We were able to do that. So recognizing the rapid risk of decompensation among these patients, we not only increased the number of clinicians on this floor, we also actually had an attending cardiologist stay in the hospital all night, in addition to other clinicians on the team. And I was one of the attending cardiologists for this floor during our surge, as Anne highlighted the numbers. And this is a new disease, a disease that none of us heard about in medical school. And the science, as many of you see in the lay press, the science is rapidly evolving. So there was a fair amount of emphasis on virtual education provided by colleagues internationally, as well as from those of us who were getting early experience with the disease. And that allowed us to maintain a high level of evidence-based standard across our group. Another innovation applied was the capability of applying specialized advanced cardiac life support measures. These advanced life support measures are coordinated by cardiology, pulmonary, neurology, cardiac surgery. Specifically, one innovation is ECMO. This is basically a machine that's external to the body that can fully take over for the lungs, even when a ventilator fails to provide the additional support that's necessary. And as necessary, can also fully take over the heart's pumping function. And it's allowed us to take care of the sickest of the sick, as Anne indicated. And, you know, as I talked about, the outpatient care has been really important to us during the surge, but increasingly so as we're thoughtful about continuing to increase our bandwidth, both remotely, but also in person. You know, patients with or who are at risk for cardiovascular disease require management of various risk factors and indices to reduce risk. And we altered our outpatient practices, and many of these have largely transitioned to virtual practice. And this largely means secure audio-video communication in lieu of in-person visits to promote physical distancing and reduce the spread of COVID-19. There was a handful of us who were doing virtual visits before, but with, you know, we had the systems and technological capability to basically have the entire group transition to a completely virtual platform. But, you know, as I indicated, there are some patients who still need to be seen in person. So we created a cardiology specific urgent care practice or urgent care clinic, and it's staffed by, you know, by all of us. We rotate through where, you know, we as cardiologists have a running list of patients that we're worried about, who we feel that the remote encounters are insufficient in assessing risk and also reducing risk. And so we have either us or one of our colleagues evaluate those patients in person. And Anne went through the various logistics of safely providing inpatient care, and that has transitioned from, you know, from the waiting room all the way, obviously, into the visit as well too. One innovation that I'm actually particularly proud of is something that we did within our preventive cardiology group, and this is the creation of a fully virtual longitudinal cardiac rehab program. So cardiac rehabilitation is an outpatient in-center exercise and diet-based intervention program. This is what patients undergo after they've developed heart disease or have heart surgery. In addition to the therapies, the close connections to our staff have been generally key in folks' recovery. And I'm really proud that we've been able to recapitulate much of this therapy and experience with real-time exercise therapy and cardiovascular education virtually. We've also teamed up with consumer electronics manufacturers to effectively use smartphones and smartwatches to deliver this therapy. And as far as I know, others aren't doing it, certainly to this scale and with all the various connected devices as well. And you know, as I noted earlier, many of us are highly engaged in research activities that complement our clinical practices. All of us have been creatively thinking about how to use our respective research tools and expertise to better understand how to predict, prevent, and treat COVID-19. You know, my research laboratory focuses on the genetics of cardiovascular disease. And in the context of an international consortium, we've been engaged in trying to understand how one's own genetic makeup may increase the risk of developing COVID-19. And even if one's own genetic makeup can confer an apparent natural resilience to developing the disease. We think that these insights can be important for repurposing existing drugs, inform new therapeutic targets, and importantly, they may yield important insights for preventing future pandemics. Now, we, within the Mass General Brigham program, have a pre-existing healthcare-associated biobank that's now about 100,000 patients that allows us to understand the specifics of the genetics also within our own patients as well. And so on a final note, as is common with many of our clinicians, as I indicated earlier, my wife and I are both physicians at Mass General. My wife's an ICU physician who took care of the sickest of the sick of COVID-19 patients. Life is crazy, but we're both thrilled that we can both meaningfully contribute. And on that note, I'll transition over to Dr. Rosand.
Thank you, Pradeep. And thank you very much for including me in this session. I too want to lead off by acknowledging with deep gratitude Anne's leadership and her team's leadership during this time of crisis. It's been a privilege to work in the hospital. My clinical role is I'm a neurointensivist, and we run a very specialized ICU that's really focused on the care of the brain and the spinal cord. But because of the overwhelming number of patients with COVID-19 who required an ICU, we converted ourselves to a COVID ICU. And so my team and I quickly learned how to take care of a complicated disease that largely focuses on the lungs and the body. We had the opportunity to work side by side with all sorts of colleagues from across the hospital, and it's hard to describe how exhilarating and how much fun it was to be learning from people you just met. The good news was that so many of our patients who were very sick ultimately did recover, and those were always celebrations. What I'm going to cover in my session is, I thought, three topics that would be of interest to the group. The first is, what do you think of with regard to brain health and wellness if you're somebody who's been cooped up at home for a long time and experiencing the real stresses of this pandemic. I also like to touch on what do we know about the impact of COVID-19 infection on the brain, and for those of us who have had COVID infection, what can we expect for our brains in terms of recovery. And then I will conclude by addressing some of the work that a very large team of neurologists, psychiatrists, and many others have begun to undertake to try and sort out the impact of COVID on the brain and how to help folks recover their brain health after COVID infection. So let's start with brain health during this time of isolation. And I'll give you a little bit of insight from the approach we take here in the McCants Center. And it's important to emphasize that the first step in brain health is body health. And this hospital and your physicians are already, are always here to help. And you heard this from Pradeep, a really important consideration during this time is that even though our hospital systems have been overwhelmed by COVID, our physicians have always been available to our patients, and we have been concerned that our patients aren't seeking care for fear of coming to the hospital. But what I can assure you is that if you want to take good care of your brains and you have a brain condition and you have any concerns, please call your physicians right away because we are all in a position to be able to take care of you regardless of what the state of the COVID pandemic is. So that's the first step. The second important thing to highlight is we have to give each other and ourselves a break. This is a very difficult time. Our lives have been upended, and to make it through with a smile is doing really well. What we have found, both for our patients and also with our colleagues whom we have supported, is that being able to allow yourselves to not always be at your best and to allow yourselves the time to reflect on the stress that you're experiencing is really vital to maintaining brain and mental health. So what are the steps that you can take, the active steps, to care for your brain? And a simple way to approach it is through what we think of as inflammation. So the body's immune system is there to defend us from infection, but it can also go awry. So for example, in COVID, when the virus infects us, one of the major consequences is that our own immune system becomes very, very active and starts to become much more the problem than the solution. It turns out that our immune systems are activated in all sorts of contexts. And when our immune systems are activated at sort of a low, consistent level, that's when we think risk of all sorts of diseases go up. And we now think that a lot of the long-term conditions of the brain, like Alzheimer's or Parkinson's or stroke, are related in part to inflammation. So our approach is to do everything possible to reduce inflammation. And so what can one do? One can eat the kind of diet that we think is associated with reduced inflammation. You've heard it before. It's those that are rich in fruits and vegetables, have a healthy amount of protein, low in saturated fat, and are rich in fiber. We always advocate reducing your sodium to the degree that you can, particularly because of its relationship to high blood pressure, which I will get to soon. And to reduce one's intake of sweets. Physical activity, regular physical activity, has been hard to maintain during this time, but there are all sorts of things that one can do. One can take walks, one can do static exercises, jumping jacks, all sorts of things in the home. But keeping a routine is very important, because those of us who are able to keep a routine during this time of isolation and, let's say, relative lockdown will be in a good position to resume a routine of exercise as we open up. Another important consideration for brain health, it turns out, is regular stretching and yoga. The degree to which one can feel slightly free of aches and pains has a big impact on the way we feel and our moods. And regular stretching goes a long way to sort of preventing the development of those aches and pains. So we advise all of our participants and patients in the McCants Center to develop some sort of a regular habit, whether it be formal yoga or something else. Sleep is very important, and setting aside time for sleep. We advise folks to find that sweet spot where they're generally turning off electronics, developing sort of a quiet time before going to sleep, and making that time the same time every night, and giving yourself at least 8 hours in bed. For some of us, enough sleep is 6 hours. For others, it's 9 hours. But in general, we recommend between 7 and 8, and working on that as a habit. Obviously, smoking has a pretty substantial negative impact on brain health, and so we always advise folks to take steps to reduce and quit smoking, those of them who do smoke. Keeping your cholesterol under control and following the advice of your primary care physicians is very important. And then for those of us who are either at risk for diabetes or have diabetes, actively maintaining your sugars in a healthy range does a lot for reducing what we call neuroinflammation of the brain. Finally, a topic that's a great favorite of mine, because the specialty of my research is in the area of stroke, is blood pressure. It turns out that we've learned that one of the biggest impacts that blood pressure has over the lifespan is on the brain. And we work very closely with our patients and their primary care physicians to make sure that they're on the right blood pressure medicines, that they're checking their blood pressures often at home to make sure that their blood pressures are well controlled. And there have been a number of studies over the past 3 years that have shown in a very elegant manner that the lower you go, and we're not advocating that anybody goes so low that they have difficulty with lightheadedness, but the lower you go, the better for your brain. So we now advocate that people work with their primary care physicians to bring their blood pressures down under 130, that top number, that systolic blood pressure, down to 120, and the bottom number, the diastolic reading, we want to get to 70. And so this takes work, exercise helps, and also keeping salt down. But the number one best way to get your blood pressure down is to measure it so you know what it is. And certainly measuring your blood pressure is something you can do at home. And if it's consistently elevated, it's something that you can work with your primary care physician to manage. Another very important component of maintaining brain health is our social relationships. We and others have found that there is a strong relationship between having vibrant social relationships and reducing one's risk for developing diseases like Alzheimer's, developing memory loss as we age. And so again, during this time of isolation, maintaining those relationships is a very good way to take care of your brain. A particular practice that we work on with our patients is meditation. There's now no controversy anymore. Meditation has a positive impact on inflammation, and it is associated with reduced risk for depression, reduced risk for anxiety. And meditation can be in all sorts of forms. There's any size out there that will work. And there are wonderful apps available for folks who want to get started, and there are books available. And our own Benson Henry Institute for Mind-Body Medicine pioneered a very simple approach called the relaxation response. But these are all different flavors of an activity I encourage all of you and all of my colleagues to pursue. Finally, I've had a number of questions from patients. Well, is it okay to start drinking because I'm at home? And the answer is that alcohol in moderation or in small amounts is probably okay, but there's no harm in minimizing it to even zero. And so we have worked with a number of our patients to help them find other ways to relax, but I am very sympathetic to the temptation, but certainly moderating alcohol is important. And then finally, it turns out that when we can find meaning in life, and there's so much opportunity to do that during this pandemic, we actually have a positive impact on our brains. And so it turns out that for those of us who are able to consistently find meaning in life, we are reducing our risk of Alzheimer's disease. And that's been studied in several large studies. And so that forms now the basis for steps that we can take. These are all steps that we can take to maintain our brain health during this time. So I'm going to move now just to focus a little bit on COVID and the brain. As Pradeep alluded to, there's been enormous research that's being done around the world on COVID as we learn all about a disease that didn't exist when any of us were in medical school. And so reports come out in everything from the Washington Post to traditional medical journals. What we are learning at Mass General is that COVID does impair the brain, but it's not permanent. I think that's really important, and I'll talk about that in a second. But I noticed that there was a question that came up through the chat about COVID and stroke. There were some big news stories a couple of weeks ago about young people who seemed to be presenting with stroke as their first presentation of COVID. What I can tell you is those cases that were reported were unusual and they were concerning, but we haven't seen that as a trend elsewhere. So we don't know yet whether COVID itself is a risk factor, elevates your risk for stroke. My guess is because of the exuberance of the inflammation that COVID causes, that we are at risk for a number of different diseases when we get COVID, but we haven't seen a super high incidence of stroke in this population, so I'm optimistic. And for those of us who have had COVID, what can you expect from your brain? It's very common after a COVID infection to feel fatigued, to have difficulty with memory, to not be able to concentrate, to feel anxiety, and also to feel a little depressed. And the good news is we're seeing that all of these challenges resolve. We haven't seen any lasting impacts on the brain yet. The disease is we're still getting to know it, but we're quite optimistic. And I'll end very quickly with what we're doing here at Mass General. We too are part of an international consortium studying the impact of COVID on the brain. The focus that we've taken on is because of the populations here in the Boston area that have been most dramatically affected. These are populations who suffer already from healthcare inequalities, and therefore the impact of COVID is magnified because of their limited access to healthcare and other services. we have focused on understanding the impact of COVID, not just on the patient and their brain health, but also on their families and their brain health. And we are now beginning to study the recovery of COVID of patients and their family caregivers, because we see them as a unit and trying to understand as quickly as possible what their needs are and how to meet them as quickly as possible. So with that, it's my pleasure to turn the microphone over to Dr. Fava.
Thank you so much, Jonathan. As you mentioned, it's a true pleasure to work in an institution like Mass General. The incredible leadership demonstrated by Anne and other leaders in our hospital has made the whole experience of working for MGH a true privilege. Our psychiatry department, which ranked #1 in the US News and World Report, is usually a trusted resource for many people, not just for our patients, but for the general public. And so when COVID-19 emerged as a threat to the health of ourselves, our families, our friends, we recognized right away the urgent need to provide a central source of information that was accurate and timely and would reach as many people as possible. Within a few weeks of the pandemic, we in the department have created a website on the hospital's main website called the MGH Guide to Mental Health Resources for COVID-19. It was an absolutely remarkable team effort. Our Associate Chief of Psychiatry for Research, Jordan Smoller, and his postdoc, Dr. Carmel Choi, are the curators of the guide, which provides a variety of resources on general mental health and coping. Some of the things that Jonathan recommended, like mindfulness tools and free apps, they're all listed there. Things to do to stay active, such as yoga, again mentioned by Jonathan. The guide includes videos and podcasts, and much of the material is homegrown here at MGH from our own faculty in the Department of Psychiatry. It is updated almost daily. It has been used by tens of thousands of people around the country and the world so far, and we even have a Spanish language website version. We've also seen with COVID-19 a rapid adoption by our faculty of technology-based solutions to improve access to treatment for our patients. We have converted most of our patient services into virtual visits, and we're now able to see even more than the patients that we were seeing a year ago. When it comes to dealing with the mental health impact of COVID-19, the first thing to understand for all of us is that it is okay not to be okay. This crisis is a huge stressor for everyone. Feeling anxious or nervous during this time is completely normal. However, sometimes the levels of anxiety and or discouragement and depression may be overwhelming. And that's why it's important to seek help in those instances. A recent study showed that 36% of Americans say coronavirus is having a serious impact on their mental health. And in fact, we talk about it as kind of a second form of a pandemic that is more affecting our mental health. In fact, the country has observed a 20% increase in the use of anti-anxiety drugs, antidepressants in the first weeks of the pandemic. The key to managing stress and anxiety, as Jonathan pointed out, is to build resiliency. That means being able to bounce back from difficult times. We can build our resiliency by doing things even for a short period of time. Things that Jonathan pointed out: meditation, yoga, connecting with people, helping others, even the simple act of calling someone who lives alone. Three things are also very important. First of all, eating right. As an Italian, of course, I appreciate that. I would say one of the advantages of virtual visits is also the home cooking, sleeping well, and exercise. And these are things that we should not consider as optional. They're very important to our mental health, and well-being at times like this. But we also face another challenge, at least some of us, with respect to how parents and their kids deal with COVID-19. I think it's important to keep in mind that anxiety is contagious. Parents need to control their anxiety in front of their kids. When they're calm or calmer, they can convey information much better. Fundamentally, all the kids want to know is, am I safe? Are my parents safe? How will this affect my daily life? And parents need to be available to use model behavior, washing hands with younger children, wearing masks outside, providing reassurance, validating the kids' feelings and concerns. Kids need structure and guidance, and different coping strategies are needed for different age groups. For young children, turn off the media. I personally feel that we should turn off the media for everyone, because they're, the obsession with what's going on TV and the press releases and all that, I think it's really having a negative effect. So protect the children from the news, the young children, but teens are more capable of understanding the nuances, and parents should watch the news with them, again, not excessively, but help them interpret the information. In the department, we have the Clay Center for Young Healthy Minds, which is a tremendous resource for learning how to talk to kids, how to talk to family members, and for things like this. Now, COVID-19 has placed additional burdens on our frontline healthcare workers who care for the sick while facing risks to their own health. Pradeep's wife, working, in the ICU, of course, frontline, and many, many nurses and doctors and staff. In a very large study conducted in China, compared to non-medical healthcare workers who didn't really work with the patients directly, medical health workers had a higher prevalence of insomnia, anxiety, and depression. And so, knowing from the Chinese experience, our Department of Psychiatry has quickly developed several online programs to help care workers with high levels of stress and work demands develop resiliency skills. Our MGH psychiatry faculty transformed 3 different brief resiliency interventions into 3 30-minute online sessions available for all employees. Freestanding mental health apps were made available to all our healthcare employees to provide introductory cognitive, behavioral, and mindfulness skills. Our own Employee Assistance Program, or EAP, provides 24/7 availability with connections to resources and services. Any employee experiencing mild to moderate symptoms of depression and anxiety could be referred to a self-directed internet cognitive behavioral therapy program, or ICBT, and an ICBT coach would assist with onboarding and with calls for 5 or 10 minutes once every 2 weeks to boost motivation and provide support. Jonathan mentioned our Benson-Henry Institute. Our faculty from the Benson-Henry Institute has developed a mind-body resiliency group adapted to the needs of frontline clinicians treating COVID-19 patients, and this 60-minute 8-session group intervention is being delivered via the hospital HIPAA-compliant online telehealth platform, and imparts stress management, self-care, resiliency skills. And finally, the CARES Clinic is a new clinic that we established to provide brief virtual individual mental health sessions for employees at MGH and MGH-affiliated hospitals who are experiencing high levels of stress, trauma, and bereavement because of the impact of providing COVID-related services in the hospital or outpatient clinics. We're offering as many as 3 virtual sessions with a skilled psychologist to help identify concerns and support staff through this crisis period, with additional referrals for more intensive therapy or medications including medication evaluation, to help with all these things as needed. So I feel very proud that we were able to put all this together to help patients, to help our own staff, and hopefully to help everyone through our website. Thank you. And Britt, back to you.
Maurizio, thanks very much, and thanks to all the panelists. I'm going to jump right in with the questions right now. We've got some very good ones that have come up. And this first one's for you. It's, is testing available for those without clear symptoms of COVID-19?
The answer to that at this point is no. We are trying to limit our testing capabilities and capacity that we have to those that are experiencing symptoms.
Okay. And Pradeep, I think this one's for you. The workplaces are beginning to roll out phasing in and return plans. For many, employees are given the choice. For our mental health, what would you recommend? Remote work in the hot summer or return to normalcy?
Good question. I mean, it's questions that we're facing in the hospital, both on the clinical side and on the research side. And obviously all workplaces are beginning to think through their phase in, especially as the government and local governments have given guidance. Our principle has been, especially for the non-clinical staff who work in my laboratory, which probably extends in other settings, is if you can work from home, I would continue to work from home. I think we don't yet have a handle on if there's going to be another phase of the pandemic, and if there is, what that will look like. And I think the best that we all can do to reduce the risk of there even being another surge is to continue to promote social distancing as possible. And it's clear that in some jobs it's obviously very hard or not possible to do remotely. And I think in those scenarios, you'd have to work with your employer to ensure there is some degree of physical distancing that's possible. What's the protection? Are people going to be wearing masks? Is there decontamination necessary depending on your type of employment? And how often are you going to be interfacing with people, and what does that exchange look like? Because I think you still want to maintain as much of the principles that the CDC has outlined as far as physical distancing and maintaining these kinds of protections. And I think that's important for the healthcare system to minimize the burden, but also for your risk and the risk for others that you interface with.
Jonathan, you talked about the importance of brain health. Could you comment on how, if at all, the social effects of the pandemic, which is the frequent negative news, quarantine, economic uncertainty, is that playing a role in complicating existing neurologic conditions?
That's a great question. I think we do know that the level of stress and anxiety that most of us are experiencing is higher as a result of the pandemic and all of the conditions surrounding it. It's certainly true that for those of us who have some sort of a chronic brain disease like early Alzheimer's or Parkinson's, stress can make our symptoms worse. And it's really important to take active steps to reduce stress. I think Dr. Fava's recommendation that we take steps to limit exposure to the news is a very sound one, and it's one that I adhere to as well. But there's no question that the stress induced by being on lockdown and being fearful can exacerbate brain disease.
So this one's a fairly complicated one, and I'm going to pitch this one over to you, Maurizio, but I think maybe several of you will have opinions to weigh in. So is there any guidance you can provide, or maybe even offer a webinar to families where there is a patient with underlying risk factors for COVID? Some families are trying to find the middle ground between teenagers and college students with a parent who may be ill. how do these families stay together and still navigate the unknown territory of society beginning to open up?
Well, that's a great question. And this is one of the many challenges that we're facing with this pandemic. That is our own anxiety, right? If you have a loved one that has an underlying condition that is a significant risk factor for a poorer outcome with COVID-19, and having young kids that we know are relatively protected, or at least they're more likely to be asymptomatic, and they want to be, I just need to go next door to the park to see all the young kids that are not exactly following the physical distancing. So how do you navigate that? And that's very challenging. I've seen some families, for example, keeping the kids on one side of the house to, not self-quarantine, but in some ways realizing that they're kind of, they're dealing with a different level of comfort with their exposure. But I don't have any particular suggestions. Anne, what do you think?
I think it's a great question. I too have heard of, different mechanisms that people have put into place. I mean, certainly, some of this we've seen publicly as well, and in making sure that we're staying away from perhaps elderly parents, people that, in the family that might be at a higher risk, but at the same time, trying to maintain good social interaction. And using any and all kinds of tools and techniques, whether it's, visiting a loved one who might be in a nursing home kind of facility, but having to stand outside the window. I think probably the bigger challenge is really with the children, and whether, it's little children who, it's hard to explain why they can't share toys or why they can't have play dates. And then, the adolescent group raises a whole nother series of challenges. And I think it's just a question of trying to provide as much education as you can at the right pitch, at the right level for the, the particular family member that you're trying to deal with. I don't think there's any magic bullet here. We're just, learning the tricks from one another in terms of what works best in a given situation.
I would just add that, there are the standard recommendations of frequent hand washing, wearing masks in public. It's all, there are these very challenging scenarios if one of us is ill at home or has a chronic illness that puts us at a higher risk. But what I found is that it's sometimes easier to focus on the complicated decisions, and then we sometimes forget about the simple things which go a long way. So I think the more simple and consistent we are with messages about frequent hand washing, wearing masks in public, social distancing, and doing frequent hand washing at home, and in some cases cleaning the doorknobs and the light switches every day. No doubt this will reduce the chances of transmission, although it won't eliminate the chances.
Pradeep, how can patients access care through the virtual cardiac rehab program?
Oh, that's a great question. As it stands today, there isn't an in-center cardiac rehabilitation. So if your physician puts in an order through the normal order entry system for referrals for cardiac rehabilitation, that will immediately send it off to our team where we can activate virtual cardiac rehab. Now, much of a lot of the online curriculum that's not synchronous, meaning that's not live patient coaching, much of those PDFs and some of those videos are actually on our website. So you can just Google MGH cardiac rehabilitation and many of the resources will already be available to you. Just as a side note, cardiac rehabilitation is largely individuals with symptomatic cardiovascular disease or recent heart surgery. We recognize that these kinds of therapies would be helpful for people more broadly. So on a related note, we're using insights from our virtual cardiac rehabilitation to try to apply these therapies more broadly. But I'd say just kick it back to your doctor, and if they order you for cardiac rehabilitation, you'll be enrolled in our virtual program.
So Ann, we've got about 30 seconds left, and I'm going to turn it over to you to wrap things up.
All right. Well, thank you very much, Britt. And again, I'd love to thank my colleagues for the wonderful insights. I learned a lot this afternoon, and it was a pleasure to be part of this panel with you. I want to thank all of our attendees. We really appreciate your participation in joining us, especially on such a lovely afternoon here in Boston. And we just encourage you, if you have further questions, so please feel free to email mghevents@partners.org. And with that, we'd just like to conclude our session this afternoon. And again, thank you all for participating.